Okay, we're going to get started. On this panel discussion, I'm going to start off with just some regulations or rules that have been that deal with the health and safety issues, and then each speaker will be given a question and answer their question, and then open it up for you can ask any specific speaker issue. But the title of this is Health and Safety Issues Associated with Obstructive Sleep Apnea and Shift Work. And I kind of put our government at work question mark, because what you're going to see is the guidelines or regulations, depending on what branch of the government, don't correlate with each other a lot of the time. So if we look at mariners and obstructive sleep apnea, there's been a major change as far as the medical division at the U.S. Coast Guard Maritime Center, going from 4 people in 2008 to 35 people in 2011, including 3 physicians and 14 physician assistants. And they credential 70,000 mariners a year. If you have sleep apnea as a diagnosis going in, to get Coast Guard license, they require the diagnostic PSG and titration study within the last 5 years. They also require demonstration of compliance and treatment, and if those are not available, as far as compliance logs are not available, they'll accept a maintenance of wakefulness test. However, there is no current requirement that mariners have to be screened for obstructive sleep apnea. However, if you actually look at the form that the physician out there gets for doing a Coast Guard physical, you'll see on that form, and you notice this is from June of 2012, so it's not very long ago. Item 179 under neurologic conditions lists sleep apnea, central sleep apnea, narcolepsy, periodic limb movement, restless leg syndrome, or other sleep disorders. And they require submission of all pertinent medical information and status reports, and that includes a sleep study with a polysomnogram. And I'm not sure what a sleep study without a polysomnogram is. Use of medications and titration study results. And then if surgically treated, should have post-operative polysomnogram to document cure or further treatment. And what I've seen, as we do a lot of Coast Guard patients in Alaska, and what I've seen is it's really hard to get by somebody with restless leg syndrome. They want the polysomnogram, and they want, there's no, it really depends on who the reviewer is there. I mean, instead of just dealing with obstructive sleep apnea in this regard, they blanket all sleep disorders into one category. So then if we look at truck drivers and getting a CDL license. In 2012, the Federal Motor Carrier Safety Administration recommended that all truck drivers with BMIs greater to than or equal to 33 be required to undergo OSA screening. And then drivers with AHIs less than or equal to 20 with no history of excessive sleepiness could be certified. Drivers with OSA were required to demonstrate compliance of greater than 4 hours on 70% of the days. However, in October of 2013, President Obama signed a bill forbidding the FMCA from using guidance to address sleep apnea screening, and said that all regulations had to go through official rulemaking process and go through Senate and House to become law. So really, there is no mandatory screening for CDLs. Likewise, you notice that the dates are similar. The Federal Air Surgeons Medical Bulletin, October was when the CDL disappeared, and then November last year, Fred Tilton, who was the Federal Air Surgeon, had this quote: airmen and applicants with BMIs of 40 or more will have to be evaluated by a physician who is board-certified sleep specialist, and anyone who is diagnosed with OSA will have to be treated before they can be medically certificated. Once we have appropriately dealt with every airman examinee whose BMI is 40 or greater, we will gradually expand the testing pool by going to lower BMI measurements until we've identified an assured treatment for every airman with OSA. Needless to say, that did not go kindly. And in May they retracted it with this letter. And it's interesting, some of the logic used. First one is pilots will not be disqualified on the basis of BMI. And they said, of 4,917 pilots with OSA, only 347 have a BMI of 40 or greater. And I think they kind of left the denominator of that out. They just gave us the numerator. So we really don't know whether there's increased incidence in airmen with BMI of over 40 having OSA or not. And then they also went on to say, OSA evaluations can be completed by any physician, not just sleep specialists, using standard criteria. And the evaluation may not require a laboratory sleep study or even a home study if the certifying physician does not feel the pilot requires it. So that's kind of where we are. You know, if a pilot is diagnosed with sleep apnea, again, they have to go through the bring in the documentation to the AME and then goes through the regional flight surgeon. So then we already talked about Coast Guard. Like if I was to go get a Coast Guard license to do a charter boat, this is for U.S. Coast Guard Air Medical Policy letter concerning OSA, and note the date, April of last year. This to me sounds very archaic. The waivers are rarely granted unless the individual was surgically treated and their postoperative PSG demonstrated resolution. Sleep apnea is disqualifying for aviation duty. Waivers will be considered on a case-by-case basis, and waivers are possible and granted on a case-by-case basis if the condition is treated by weight loss, dental device, surgery, or the use of CPAP devices with documented resolution via PSG. But it goes on, it says, the results of PSG to confirm and post-treatment PSG to document improvement, they have to have an ENT or pulmonary consultation. So for some of us that are sleep specialists, we're out of the loop, and if you're a neurologist, you're out of the loop. And if a dental device is used, oral surgery consultation is required. And there's a note of current treatment of the condition, copy of the operative report. But the other part I like is functional testing post-intervention, a maintenance of wakefulness test, or a mean sleep latency test. I don't know what a mean sleep latency test is, but I'm not sure that that's an appropriate test for this, and we'll probably discuss that a little bit later in this. And then their bottom line treatment is weight loss is the simplest treatment, and a loss of 10% body weight can result in symptom resolution. May be true, but even on bariatric surgery, remember, the rate of complete resolution of obstructive sleep apnea is only 50% in those patients. Identification of risk and treatment of risk factors such as obesity and hypothyroidism may lead to resolution. In some cases, modification of sleep position may be adequate. Dental devices that modify position of the tongue or jaw or upper airway and jaw surgical procedures such as UPPP and laser-assisted uropallioplasty are additional therapies. Nasal CPAP is a common treatment, but may be challenging in the aviation environment with possible deployments. So that's kind of the obstructive sleep apnea is where it is as far as regulation involving major groups. So let's look at shift limits. July 2013, trucking regulations changed, and the federal rules said that your maximum work week has gone from 82 hours to 70 hours. Those drivers that hit this limit have a mandatory 34-hour resting period, and it has to include 2 periods of no driving between 1 a.m. and 5 a.m. because that's the most likely time that you're going to fall asleep. And you cannot drive more than 11 hours per day, and you have to have a 30-minute break during the first 8 hours of the shift. So shift limits for maritime shipping. Deck watch on a vessel off duty for at least 6 hours within the 12 hours immediately before leaving. If you're on an ocean-going vessel that's less than 100 ton, the individual may work no more than 9 of 24 hours when in port, including the date of arrival, and no more than 12 of the 24 hours at sea, except for emergency or when life or property are endangered. At merchant vessels greater than 100 ton, a licensed individual may not be required to work more than 8 hours in any one day. Railroad. Railroad has nothing about sleep apnea. However, they do have shifts. And the Railroad Safety Act 2008 said on duty unless that an employee has had at least 10 consecutive hours off duty during the prior 24 hours. And the duty for a period in excess of 12 consecutive hours and no more than 6 consecutive days. So how about physicians? I have a truck driver friend that says, he says, you guys are unbelievable. You guys can go out drinking all night, you can be up for 48 hours, and you come in and they hand you a knife and tell you to go in and operate on somebody, and it's really true. But physicians in training is a little bit different, and JACO report in 2007 found that physicians in training working traditional schedules with recurrent 24-hour shifts made 36% more serious medical errors than those whose scheduled work was limited to 16 hours, made 5 times as many as serious diagnostic errors, had a 61% increase in needle stick injuries after 20 hours, and doubled the risk of a motor vehicle accident when they left work and were driving home. So as a result, Council of Graduate Medical Education 2003, residents should work no more than 80 hours per week or 24 consecutive hours on duty, should not be on call more than every 3rd night, and should have at least 1 day off per week. So the last category I want to talk about is VA obstructive disability. We in sleep labs get a lot of active military about 1 month before discharge wanting a study, no matter what body habitus they are. And the reason is the diagnosis of CPAP-dependent OSA is a 50% disability for life. And that compensation for that disorder is likely to be over $1 billion this year. So if you look back to 2001, the VA had 983 veterans registered as disabled for sleep apnea. 25,000 last year. 3% of all veterans with service after 9/11 and who draw VA disability pay are being compensated for sleep apnea. It's been asked, we're going to open up the questions. First question is directed to Dr. Hill. It's been estimated that as many as 42 million Americans have significant sleep disordered breathing. Can you briefly give us an overview of what this means from a safety perspective in the workplace?
Briefly?
You got 8 minutes.
Why don't I tell you what a mean sleep latency test is? It's when the examiner hurls insults at the patient and times how long it takes for him to fall asleep. But in relation to this question, clearly sleep disordered breathing is a major societal problem anyway, and when we get into the workplace, it just becomes magnified because the consequences become greater. And the more serious the job you have, the more likely you are to cause harm, so it becomes a big public health issue. And this is certainly very important when we're talking about truck drivers, school bus drivers, pilots, train engineers. It's interesting that the train people don't monitor this. I guess you get the impression if you read the papers that maybe they're using cocaine to keep themselves awake or something, because some of the accidents they've had have been associated with that. Then you pointed out that you also have physicians and military people and so forth. So the implications of things like this are huge. I guess the Exxon Valdez, although it was probably alcohol related, may also have been at least partly related, because I think the captain turned out to have sleep apnea in addition, and if you combine alcohol and sleep apnea, that's a big problem. So at a very simple level, I think we can all appreciate that if someone has sleep disordered breathing, and the worse it is, the more likely they are to be fatigued. And fatigue is associated with inattention and a higher error rate, as we saw with those physicians. And if you're doing something involving the lives of a lot of people, flying an airplane or in a train or something, a mistake can be extremely costly. And so it is a major problem. Now, how to deal with this problem is extremely complicated, and that's why we're seeing these inconsistencies. That's why undoubtedly Obama backed off on these guidelines, because if you are a pilot or a truck driver or somebody whose living depends on your working, and somebody says you can't work because you've been diagnosed with sleep apnea, that is a major problem. And if you belong to a union or something, your union is going to fight like hell with the politicians to get the policies revoked, which is clearly what happened in that case. But how to create rules that make sense and are fair and don't harm the people with sleep apnea too much is a big challenge. Part of the problem is, as Paul pointed out earlier in the talk, when you try to lump all these sleep disorders together, you get a fruit basket of problems, and how do you apply one guideline to that? And furthermore, even when individuals have the same kind of sleep disorder, their responses to it may be different. People have quite a variable requirement for sleep. Some people are fine on 6 hours of sleep, others need 12. And so how do you come up with 8 hours for everybody? And furthermore, how do you enforce it? There are ways of monitoring when people are using their CPAP, of course, but there are ways of gaming that, and how do you know that the CPAP is being effective? You can look at MSLTs or polysomnograms afterwards. It can get extremely expensive. We also heard about this example of the VA people who would love to be diagnosed with sleep apnea, unless they're planning to become truck drivers afterwards, I suppose. But I want that. Retiring physicians, I don't care about work duty hour restrictions now, but give me that retirement deal. Now, as a physician, the way I've become most closely aware of these shift work restrictions is what Paul mentioned about house officers and their work restrictions, and anybody who works in a teaching hospital is well aware of this. When I do rounds in the morning, for example, we have an on-call team, and they always present their patients first so that we can get them out before the witching hour occurs and they turn into a pumpkin. They're very strictly enforced rules, but they have a lot of unintended consequences. And part of it is they're not around to see what happens to the patients they admit, so they miss out on a lot of exposure and experience. They're not around to do procedures. They're not around for teaching rounds. They have to leave the hospital, and what they do when they go home, we have no idea. We don't know whether they're resting or not. Even the house officers don't like it because they feel they're missing out. And last year, at the end of the year, the house officers put on this humorous skit. Last year, the theme was work duty restrictions, and they had work duty restrictions 2020, and so they had an intern working for 10 minutes and then having to take a 4-hour nap, and it's getting to that point. So, as a broad overview of the situation, yes, I think we all are concerned that people who are responsible for our welfare in these very sensitive situations, flying, riding on buses, and having truck drivers that are passing us on interstate highways and so forth, we want those people alert and aware of what they're doing, but we also have to come up with reasonable ways of putting together regulations so that they're assuring our safety optimally and also are being fair to those who might be harmed by these rules. And how you come up with an ideal solution is extremely challenging, and obviously nobody's found it yet.
So the next question is for Dr. Lee Chong. We frequently get requests from government agencies or employers requesting MSLT or MWT to clear a patient with OSA for licensure. Can you address the appropriateness of the test requests and how you would suggest we manage these requests?
wasn't prepared for that. Can you hear me? So let me just explore a bit what Dr. Hill just said. You know, we have to take a step back and look at the picture from a blue sky approach. The goal really is to achieve and maintain the highest level of safety for the public, right? Whether it be at the workplace or in a plane or in a train or in a school bus. Unfortunately, alertness and wakefulness, which is what we're concerned about, is only one element of a very complex accident proneness. Okay, so let's say inexperience could be partly to blame for that. Distractibility, personality behavior such as risk-taking can also play into an accident. So the question has always been whether we alter the human behavior, in this case sleep, or whether we can use technology to provide us fatigue countermeasures. If you look at modern day cars now, there is technology in place to prevent accidents. If you look at hospital settings, there are EMR systems that will check the wrong medication dose, that will check for drug interactions. Working in a team, for example, in the ICU, will also prevent errors from occurring because you have other people right there who are equally responsible for the care of the patient. So there are technological advances that are being developed today that will surely mitigate some of these accidents. But before that time comes, we have to change human behavior a bit. And unfortunately, the only human behavior that we are interested in today, at least as far as safety is concerned, is A, sleep duration, and B, sleep apnea. Okay. There's very little else on other sleep disorders. And there's very little else, for example, in addressing shift work. Okay. There's very little else in addressing circadian influences. Jet lag for pilots. I mean, these are things that are equally important as well. The question that was asked of me was whether there's an objective measure such as MSLT or MWT that can be used. Now recall that when the current version of the MSLT and MWT were developed 8 years ago now, there was tremendous discussion as to the threshold for safety. In fact, we found no threshold for safety in every minute of the MWT. That's why we chose the 40 minutes. A person has to be awake every minute of those 4 naps in MWT to be considered at the highest level of safety for the public. We found no data that at any lower threshold is there a safety safety threshold. MWT is clearly a test that we use for maintenance and wakefulness tests as safety, and that's 40. When you look at MSLT, things are a little bit different. There was a tremendous range of both normal and abnormal. In fact, when we were looking at the data, we were faced with the dilemma of not knowing what exactly is a normal MSLT, sleep onset latency. The numbers range from as low as 2 minutes to as high as 18 minutes. Okay? So when we were faced with, like I said, a decision to choose a particular threshold, we chose 8, okay? But we also qualified that into different disorders. So if you have, for example, sleep apnea, or if you have narcolepsy, then those numbers may change a bit. 8 was just what we chose as probably the most easiest to recall. Because the testing is critical for standardization, we have to be sure that the test is done properly. That's why there was so much emphasis on how the test was to be performed. However, we also realized that treatment has to be individualized. Okay. So if you look at the MSLT and MWT data, we were rather strict when we wrote the paper on how to do the tests, we were less strict on how to interpret the data. Okay. I hope that answers your question.
Our next question goes to Dr. Glass. Currently, pilots, truck drivers, and mariners all fear the consequences of being labeled with the diagnosis OSA. Can you briefly discuss the pros and cons of mandatory screening?
Yeah, so is this working? Can you guys hear me? Can you hear me now? Can you hear me now? So I think some of this has already been covered by Dr. Hill, excuse me, a little bit. And I think the bottom line is, from my end, I'm always thinking about, how terrible it is when people are sleepy every time I get on the Glen Highway. And I think about what it would be like to be the moose that gets hit by the sleepy guy, or the kids in the school bus. And just in the course of my life, seeing the Exxon Valdez, somebody crashed into the Golden Gate Bridge when I was there and they fell asleep. And I think the data for why we need to do this is sort of overwhelming. But to put yourself in the shoes of truck drivers or other people whose livelihoods depend on this, and I sort of, in preparing for this question a little bit, I got sucked into some of the comments on these sort of bulletin boards on the internet, which is a dangerous thing. And it basically, you sort of hear everything that ranges from the sort of liberty, stay out of my life argument, which is pretty pervasive, to other sort of much more practical things that I didn't really think about, which is, well, who's paying for this, right? So these are guys that don't make an enormous amount of money, and they're about to get forced to take relatively expensive tests that their low deductible or high deductible insurance plans aren't going to pay for, and that they're going to be held to. The second thing is that they question the accuracy, and reasonably so. I read one guy who made a comment that said, basically, I went into the sleep lab, I told them I sleep on my side, they said sleep on your back, and I tried to sleep on my side, and they said sleep on your back. And the whole night I slept on my back, and they said I have sleep apnea. And I told them, my wife says I never snore when I sleep on my side. And so, is that an accurate test? I don't know. That guy might have positional sleep apnea, and it might be totally fine for him to sleep with tennis balls in the back of his shirt or whatever we always say that nobody ever does. But in reality, there's some questionable about accuracy there. The other issues that come up from them are, well, can I do a home test because it's cheaper? And the other piece of this is that if you look further on these sort of comments, it's like, well, you can stick the home test on your wife, and she probably doesn't have sleep apnea, and then you'll be fine. And so there are problems with the accuracy there. And I know some companies are actually working to sort of fingerprint these to try to be able to make these more universally available. I think some of the other problems that come up, that trying to skip over the things that I had come up with that already got discussed, it's really hard, this sort of cutoff levels. We use 20 because that's where, really the bulk of bad cardiovascular outcome data is. But I don't, I've had tons of patients, and we talked about this morning, the CHF patients that aren't tired. And should we care about what they're doing for their own long-term health if they're not sleepy and at risk of falling asleep? Because they'll say, you shouldn't if I'm not sleepy. And there really isn't always a great correlation between AHI and the level of sleepiness, which is what we're really looking at. I think one of the last things I kind of wanted to bring up was a couple of these guys had made comments that sort of said, it's kind of ridiculous that I can go out and get absolutely drunk out of my mind for weeks on end if I'm on vacation and nobody cares. But if I don't wear my CPAP machine and my card says that I didn't wear it when I'm on vacation and I'm not trucking, then I'm on the hook now. And I thought that was kind of ironic that they have no sort of mechanism for, taking a day off, or if they go hunting and didn't take their machine with them or just missed the cutoff. And more to their point, the reality is as we talked about earlier, well, what if they were, 69% of days compliant? Do they now get to, be on probation for 90 days from their job, and their livelihood is dramatically at stake? And a lot of these guys are not guys that are have an enormous amount of time, from paycheck to paycheck kind of situation. So I think from their perspective, there are a lot of problems in the way that we do this. And I think we have to be careful. The flip side of that is that this is a very, very dangerous situation, and it does sort of potentially impact a lot of lives. And so coming to some kind of reasonable agreement, which I don't know how that will ever happen, honestly, but it is really important. The last thing that I read sort of over and over again is that they talk about how texting is way worse than driving sleepy. And I would have to say, I don't know what the data really is, and you guys may actually know better than I do, but I think that's a very valid point, that we should both deal with both of those issues as well as we possibly can. Because as a person who, I know better, but like if Dr. Dodge is texting me, at a stoplight, I'm going to answer it, and I might make it halfway out of the stoplight answering that text. And I know better, right? But there's something about that, and I think that's something that we as a society need to have a technological solution for. So that's it for me. Hopefully I sort of answered the question.
Thanks. Our next question is for Dr. List. Physicians and healthcare providers in this country are one group that's been in complete denial of the effects of shift work and sleep deprivation on their own performance and outcomes. The European Working Time Directive requires a 24-hour rest every 7 days or a minimum of 48 hours rest every 14 days. There's 11 hours of continuous rest in a 24-hour period and a 20-minute break when working time exceeds 6 hours, 4 weeks of annual leave, and a maximum 8 hours of work in 24 hours for night workers. Can you address the pros and cons of such regulations in this country?
I want to make a few comments in general and perhaps specifically. The one comment, and it's been shown very clearly, that residents have higher rate of mistakes and so on and so forth when they work past a certain number of hours. The thing that's always been curious to me is that once you become an attending, all of a sudden those things go out the window. They don't apply to us anymore. Now we're macho men, and we don't go by that. Well, and the way our medical system is set up is we don't really have a choice. If you're on call and you have a busy night and you're seeing patients in the office the next day, you're basically going to be there have been patients that are waiting months to get in to see you, and you have to tough it out, and you're not 100%, and so. I'd like to digress a little bit more about some of the more general issues that we're talking about today, because I think it's very important. First of all, I think the approach that we're taking is probably not the correct one. Now, mind you, I don't necessarily have answers or solutions to this, but as we see mandatory testing, these are punitive measures. I mean, individuals who are subjected to these testing procedures are being punished because they're going to lose their livelihood, they're going to lose their income, they're going to lose their ability to do what they're trained to do. And so I think texting is a very different issue, because we have ways of proving that that person was texting during the time that they had an accident. The biggest issue, I think, with sleep disorders, and this is for the researchers, we need to find some way of determining our level. I mean, I don't know if it's with a test. I don't know if it's, an equivalent of a hemoglobin A1C or something. But until we can do that, I think we're not entirely going to be able to regulate or have some reasonable way of dealing with this problem. When we can't measure what we're trying to regulate, we can't do it. I mean, we just simply can't do it. And again, I mind you, I don't have the solution. One thing that I have thought about, and this is also doesn't necessarily work. I'm a private pilot, and during my pilot training, one of the things that the FAA requires is that every time we climb into the cockpit of the airplane, every single time, we're supposed to do a self-assessment. And they talk about things like emotional. I mean, did you have a death in the family? Did you have an absolute horrible day in the office? And you need to do a self-assessment, and I think that's on a day-to-day basis. Again, is there some way, and it's not particularly, again, people can cheat about that also. I mean, I still have to get my flight to, Valdez, or I still need to do this. But I think something where the individual takes some responsibility of a self-assessing. I mean, people know their bodies. People know how much they've slept. People know how much they drank the night before. And I don't think there's any way of universally, but these things have huge consequences when they run ships into reefs, when they run airplanes into things, and when they land airplanes in the wrong airports. I mean, some of these things, I just think that the overall big picture, as an ENT, I see people, the regulations for hearing loss. I mean, people will get around these things all the time. They manage to get around them partly because the consequences are very significant for them. They lose their job, they lose their livelihood. And so I think we need to approach this from a different perspective. I don't have the answers, but I think perhaps self-assessment or developing something where we can approach this from a different angle. As we're doing it right now, it's punitive, and we have, I don't think it's going to ever solve the problem that we're having. So there's some bright people here. Let's think about looking at this from a different direction.
This is a point that I had struggled with for a long time. I don't agree with the report from Boston about the residents in training, okay, for many reasons. If we look at the markers that they track, the needle stick injuries, the errors of medication, anything else, those are things that today we have the technology to change. There's technology out there right now that can eliminate needles, okay? Why not use them? There's technology today that can use EMR in a real-time setting, either with your iPad or your phone, to correct for and monitor drug selection, doses, and interactions. Why not use those? There are teams within the hospital now that are available to take over if you're too tired. Hospitalists, for example, are not present when they were not available when the study was done 8 years, 10 years ago. So I think simply changing the number of work hours might be good, but the consequences are such that training is affected. But also, if you remember, when they changed the workforce hours, the initial improvements were that there is a reduction in, there's no reduction in error rate. There's no reduction in accidents. The only reduction was in, it's a very strange term. It's satisfaction with their work. That was the only thing that improved. Because once you reduce the amount of work schedule, it doesn't necessarily mean that the medical resident is going to go home and sleep. The medical resident can go home and play golf or play Nintendo or go drinking. So, you know, so there's really no way to prevent this person from being awake while they were home. Again, Nick?
Yeah, I agree entirely, and I also think that you know, that there are many layers of redundancy in the system. So if you even were able to show a reduction in the number of errors, and it would be extremely difficult to show that anyway, but even if you could, if you're talking about especially first-year residents, they really shouldn't be in a situation where they're making key decisions on their own. There are people, they have you know, second, third-year residents, fellows, and attendings in my hospital who are overseeing what they do. So, and most of their errors are not related to being sleep deprived. It's being related to, yeah, they don't know enough to, yeah, exactly. So it's almost an artificial situation. I think the study you're referring to was Chuck Seisler's study. Yeah. Yeah, Chuck was a classmate of mine in college, but you know, and he's a very bright guy. There's no question about it. But I think it was kind of an artificial circumstance that he set up. And if you really want to look at the impacts of these things, I think you have to look at patient outcomes. Are patients actually being harmed less in this restricted hours system than without it? I do think there's a good rationale for enabling people to get enough sleep. And you know, when you and I and Shirok trained, you know, in the days of the Giants, it was crazy, and we were too fatigued. And you know, errors aside, it was just bad for health. But once people are guaranteed a reasonable amount of sleep on a nightly basis, you know, forcing them to leave or restricting them to, you know, very tight schedules, I don't think makes sense for a lot of people. And it's squeezing a whole lot of square pegs into a whole lot of round holes. And the system that the systems that we're seeing that people are trying to set up just don't allow for individual variability. They don't, and I agree with what Dr. Lass said about the fact that, you know, if we can't measure it, how are we going to enforce it? And that's a big problem.
I used to come to the hospital at 8 a.m. and go home the next day at about 5 or 6 p.m., and then sleep at home, come back, and repeat the cycle. So that was my internship. That's amazing how it is now.
Yeah, when we were taking every other night call, the problem was that is you missed half the good cases. Right.
There is a cultural shift that occurred about 10 years ago. It used to be that the surgeon cannot be questioned, right? Nobody can question the surgeon in the OR. Nobody can question the kill in the ICU, okay? But that has changed a bit now. Now there's a sense of teamwork. There's a sense that you can question somebody's judgment, okay? There is, for example, in the OR, there's sponge counting now for errors. There's a very formal sense that you stop what you're doing to reevaluate. We do that also in the ICU. We don't allow the younger residents now, especially interns, to make major decisions without consultation. These things were taken for granted before. I mean, we were so busy in other things that we allowed certain things to occur, which we think now is contributing to errors. But with those change in behavior, with the current change in technology, and with the current emphasis on safety, I mean, I'm not sure what any of this is adding to that. Okay, I'm not sure.
I would say even as a younger physician, I sort of read and see as some of my colleagues work their way through first, second jobs, et cetera. And one of the things that I do think goes away when you become more of a shift worker is your ownership of patients. And I think that's what we love about this job. And I think that's one of the things that we have to be really careful to protect, because you lose that. And basically what you lose in, or I guess make up for in lack of sleep deprivation, you lose in patient sign-out errors. And I think that's the thing that sort of goes unspoken. But I think in physician satisfaction, the thing that gives me satisfaction is not going home early and playing golf. It's that I went to bat for a patient, and you know, when I go home, even if it's late, you did the right thing. And it's because you felt it, you know, not ownership of that patient, but they were your patient and you took care of them, and until the job was done, not until whatever JCO said you need to go home. So.
Next question, Dr. Javahari. Much of Alaska's workforce in the oil fields work 12-hour shifts with 2 weeks on, 2 weeks off. In addition, we experience huge shifts in daylight from summer to winter. What can we do as providers to help minimize any adverse health effects?
I don't know.
Perfect. Neither do I.
Ready to go home now? I really don't know. I think I have more questions than really answers. So let me start by thinking about what does the fast shift working is going on, and then this is a very slow shift working. And just to put in perspective, I don't know if there is this is better or worse comparing fast versus slow shift working. So I think we need more data. So when we think about shift working on a regular basis, i.e. 12 hours, couple nights, and then off, couple nights, or whatever. So we are aware of certain issues there that I don't know if, again, is applicable to the slow shift working or not. So, and these are, I think, some of the research questions that really need to be answered. And I think you can do studies here to answer these questions. So, for example, there are data on fast shift working that this may be associated with hypertension, GI symptoms, cancer, especially in women. For example, in the nurse health studies, as I mentioned, the nurses that were working, shift working, had more breast cancer than others. Maybe prostate cancer in men, which may have to do with melatonin, which is an antioxidant. And in these individuals with shift working, it is misaligned. So that may be part of the problem of the hormone-related cancers. So my question really is, first of all, are these some of the issues that are you seeing here, or is this more related to fast shift working? And are there plasticities that may occur in the brain with this slow shift working. What is the prevalence of shift worker disorder in this paradigm? Do we know that number? No. For example, we say about 20% of shift workers in the United States have the disorder, but again, I don't know if this is the same number when you rotate like this. So anyway, I think there are really more questions here that I can think of, and I think if in this area you can compare 3 groups, those without shift working, those with fast rotation versus those slow rotations. If you can answer some of these questions, prevalence, complications, side effects, whatever consequences, that would be extremely important. Again, I know what we should do to promote better sleep in fast rotation shift working, but I don't know what we should do in your situation. So, and again, right, in somebody who's shift working, we have 3 problems, basically. The misalignment, which is both for day and night. So that's 2 problems. They're supposed to work when they're supposed to sleep, and then they're supposed to sleep when they're supposed to work. And if you can take care of either one of these, the other problem may not go away. For example, if you give a hypnotic to a shift worker to sleep during the day, still that person may have hypersomnia while working at night. So these are really separate issues from each other. And then, of course, these people have sleep fragmentation and short sleep, which is a 3rd issue here. Now, in Alaska, the 4th component would be the circumnual changes with the 6 months light and 6 months dark, which is another superimposed problem. So I think some of these things have to be resolved. But anyway, I know what we should do for people who work 12 hours at night and then go home and should sleep better. I know what I should do, tell them, but I don't know really what you should tell your folks. So for people who work at night, we generally recommend light exposure at night before they go home, and then getting close to going home, we tell them to wear a goggle, darker glasses, not to be exposed to sun, of course, while they're going home. We tell them to have everything dark and so on and so forth that you know all about. A lot of these people sleep twice, one in the morning, and then they get up and do their errands and take a nap before going to work, which is also good. So we know exactly what we should tell folks that work on a rapidly changing shift, but I really don't know the answer to the question that you're addressing to me, and I don't know if there's any data.
Actually, this is more of a question also. The slope workers are kind of in an isolated environment. They don't have drugs and alcohol up there. I'm fairly certain of that. I mean, very rarely might there be. But they don't have a lot of other distractions and things. And so how does that overall kind of contained environment, do we have any information on issues about that?
I don't think we do, but obviously they're having more and more safety meetings all the time, as you know, after BP's Gulf of Mexico. So now there's a lot more safety meetings on the slope in regards to a lot of different things.
Yeah, but
they talk about sleep.
The slope would be a little bit different than the Gulf of Mexico,
Right.
stuff. I mean, because it's a contained environment. Actually, that would be a good place to study some of this stuff, because you've eliminated. There's certain variables that are eliminated out of that.
I just want to make a couple of comments a little bit about other issues since I have taken care of so many patients with circadian rhythm sleep disorder. I'm talking about shift workers particularly here, and a lot of truck drivers and that have obstructive sleep at the same time. When I have looked at, let's see, by December 2013, I had 12,500 patients actively being followed, and I do not remember a truck driver that came to me that with some symptoms of sleep apnea, either by himself, herself, or by the spouse. In fact, I think the truck drivers don't snore, the truck drivers are not sleepy, and this historical stuff about the airport and so on and so forth are really useless. You mentioned about the chain of custody. So home studies should not be performed to rule out obstructive sleep apnea in these patients. Some of the home gadgets have things on them that the patients have to wear them and they can't take it off themselves. So if you're doing a home study with some of these gadgets, you have to use those gadgets that they can't put on somebody else. So there are some important issues for these individuals that we need to consider to make sure that we are diagnosing obstructive sleep apnea, which would be another cause of being sleepy, of course. So these are very important issues. In fact, it is really unfortunate because a number of these patients that have come to me, they are very upset that they were sent to me by the company because their neck size was 17 inches or whatever. And so I tell them that you should do a sleep study, and they said, well, no, I'm not going to do a sleep study. Why do you say I have to do a sleep study? I don't snore. Here's my wife. Do I snore? No. And so completely deny every symptomatology, and yet, of course, you do sleep study on them, and a lot of them have obstructive sleep apnea, and then you have to treat them. And there is a short period where if they don't diagnose and treat, they're not going to be able to go back to work. So it's really a complicated situation with them, and it's an unfortunate situation.
Last question, Dr. Dodge. In light of the monetary incentives that exiting active military personnel have in obtaining the diagnosis of CPAP-dependent OSA, what interventions would you recommend when it comes to testing and counseling these personnel?
So just to touch real briefly on the question that was just asked a second ago, I'm always kind of taken aback by the impact that the educational component we can give people in clinic visits or in the sleep lab or just in passing to friends and family. And the example that I would use is the patient that will come to see me for the 4 o'clock appointment with a 24-ounce Rockstar, and I will ask him why he is there, and the response will be, well, I can't sleep, man. I think it's the light up here in Alaska. And then tosses the can in my trash can. And so I think that, and it has been referenced here a couple of times, but that important component about the circadian rhythm disorders, and in addition to people with have clinically proven obstructive sleep apnea or sleep apnea syndrome, is the basic tenet is knowing, how to set yourself up for a good night's worth of rest. And it's very, very simple stuff, but the degree to which it is overlooked is mind-boggling sometimes. Okay, so the question that is asked of me, I think, is a fantastic question. I think it is also an incredibly dangerous question. And the reason that I say it is so dangerous is because we do not want to lose focus of the fact that when people come to us with a clinical question or a concern about a medical disease, that's what we're supposed to treat. And the obvious morbidity and mortality consequences that we've spoken about with sleep apnea are quite clear to everybody in this room, and there's lack of that depth of knowledge often in the referring base. So that's our primary goal, right? Is if somebody does have sleep apnea, to treat it effectively so that they can have a benefit both in how long they live and also the quality of their life, and of course their bed partners. The reason it gets dangerous, though, is because the DoD and the VA have tied an incredible monetary incentive to this diagnosis. And so like Dr. Raymond had said up there, the number I think was $2 billion with a B. And so what that breaks down to for the individual person is, so a single guy who is married that is diagnosed with obstructive sleep apnea for the rest of his life is going to collect a paycheck for $1,000 a month. If that guy has 2 children, and the interesting part of this equation is also if they have a living adult parent, that somehow factors into how much their monthly payment is. But so if you've got 2 kids and a mom or a dad who is still alive, you are up to almost $1,500 per month for the rest of your life. So it's not chump change. And so the problem therein is that you have a very skewed bias on the patient that's coming to you for an evaluation. So there's basically 2 groups of people that are going to fall into your office. And one group is going to be the active duty person who wants to maintain active duty status, wants to make a career out of it, and is a long way away from retirement. And that person is terrified, right? They say, if you diagnose me with this and give me a CPAP machine, can I no longer deploy? Am I going to have a duty restriction? Am I going to get boarded out or riffed? Am I going to be part of this reduction in force that's ongoing right now? And so that person is approached differently than the person who says, I'm on terminal leave, I have been so for the last 2 months, I've got a house I just bought in Southern California. And the social worker who I met with at my VA entrance interview said, have you ever in your life snored? If so, that must be documented, and you must have a sleep study. So that's what hopefully I can kind of pick out, is give some general awareness of, the two different people that are going to come into your office looking for an evaluation related to sleep, and then how you approach it. The first point is quite clear. It says that anybody who is active duty service, regardless of what branch, cannot get a home sleep test. That will not qualify for any type of VA service connectability, and it actually is probably going to get thrown out for what we call the medical evaluation board process, the procedure by which you determine whether somebody has a limitation to deployment. So any active duty person, whether it's Coast Guard, Navy, Army, Air Force, Marines, has to have an in-lab study. There's ongoing conversation about potentially changing that, but until the biometric assay portion of that test improves to the point where it's functional and readily available, it's not going to go anywhere. The second point then is our criteria for diagnosing sleep apnea is not concrete, right? So we have ranges of RDIs or AHIs. Sometimes people use them interchangeably, sometimes not, depending on what your scoreable events are. But it's not concrete. It's not such that if you have a mole that you want to be removed, your dermatologist says, there it is. I can cut it off and it's gone. It's, do I have sleep apnea? And you say, well, your RDI was 7.1. Your SATs looked pretty good. Your sleep was mildly fragmented. Are you tired during the day? Yeah, I guess so. Well, now you have obstructive sleep apnea syndrome. Hence, you have the diagnosis, and you're entitled to $1,200 per month for the rest of your life. So people know this, right? This is not a secret. So this is a very shared bit of information that goes across the, all ranks of the military, officers, enlisted folks. And so they know that, so it's not going to be a blind conversation you're having with these people. So what I would ask, or what I would recommend, is that there is very judicious use of the diagnosis of obstructive sleep apnea syndrome. And that the concrete, as much as you can be, approach to diagnosing these patients is going to be either with a proven comorbidity, which relates to obstructive sleep apnea. That's a long list, so it's not that it's going to be hard to find if there is one that is pertinent and exists, or you have clear daytime functional limitations or true symptoms that you can attribute to the RDI of 7, and not to the fact that a person just doesn't go to bed because they drink rock stars at 1600 and then play video games all night long, which for a lot of the patients that come for an active duty evaluation, that's their problem. Most of these guys are going to be 20s and 30s. They're going to be healthy overall, except for joints and aches and pains that come with, active duty life. So it's really important that the clinical evaluation, the history that you take and the assessment that you do is weighted as heavily as the results of the objective test, which is going to be a sleep study, because if those two don't blend up together, then number one, there's going to be potential misuse of funding. And number two, what patients lose sight of, especially these younger guys, is that this is not a clean diagnosis. And so it doesn't come without some strings attached. And so when they're now separated and they're looking for a life insurance policy for their family or a disability, evaluation or something that is now has a medical connected, is medically connected in some way, shape, or form, they're going to be limited because of that. And the question is, how real was that diagnosis in the individual? So, for a quick summary, the main takeaway is no home sleep test. Cannot be used in the active duty population. And then the other big point is, because there is such a financial incentive for this diagnosis, is that I would like to be as clinical as possible in making the diagnosis, and then have the sleep study be used to confirm what you think you already knew. And if those don't go back together, I think there needs to be more discussion on the clinical side at least.
Very good.
I'm going to refer you to Barack Obama to answer that question. Although you bring up a really good point, and that is why there is, and I've had this relayed to me by multiple patients, and that they are instructed. And again, we don't want to lose sight of the forest, which is we're here to treat a medical issue that in the majority of cases warrants therapy for lots of good reasons. But some of the instructions that these people will be given is you have to make sure that somewhere in your active duty military medical record, it is documented that you snore or are tired or have witnessed apneas. And so that's the piece that ties it into while they were active duty, and how you would pre-screen them prior to service and then post-screen them afterwards. That's a very complex issue. I don't know how to answer that portion of it.
I actually have a reverse situation. I had a subject that sent down, guard, full-time guard for breathing. I deal with infectious disease out there.
Up here. We have extras up here.
So while I was dealing with this person, and it just was coincidental that the PA on the base at Greeley was phenomenal. So this person was a shift worker, but that's not why I was seeing this soldier. It was for infectious etiology. And I wanted this person on a wakefulness promoting agent, not a sleep agent. But the person was afraid that, I'm trying to be cryptic in case you know all these people, I don't know, but was afraid that this med board thing, which I'm not military, so I didn't know anything about this, would use it against them. And so, but I still believe that it would be beneficial to this person. So the PA did intervene and make sure that that didn't happen. But we've got a lot of bias and prejudice going in both directions here. So I wasn't dealing with sleep apnea, but there are medications that are used for other reasons, and this wakefulness promoting agent, it was Nuvigil or Provigil that I wanted this person on, that it would be used to say that they needed to be out of the military.
Yeah. So. No, it does, and that's another really good point, is that it's always worth engaging with the active duty physician that's taking care of the patient, because there are lots of implications either for the diagnosis you give or the medications that you administer. And sure. And so I think what I would advise there is that it's always safe to, once you instruct the patient, to give them ownership of part of the responsibility for that. There are a litany of medical therapies that are duties not to include fine. So if it's a pilot, for instance, suddenly now they can't fly because you've given them Zyrtec or Doxepine. So those considerations are important to go both ways. But it's not an excuse for the military physician not to be available for conversation on our part. And so that's where I would either engage the patient or never hurts to. Okay.
Any questions for any of the speakers?
Can I actually answer it? I just wanted to comment on the previous question about sort of as a taxpayer kind of situation. And I think this came up, actually, so I was the director of this Parkinson's Center at the VA in San Francisco, and it was affiliated with UCSF. And while I was there, the VA decided to honor the Institute of Medicine report and service connect Parkinson's disease, right? So it was like a windfall of money for all the patients that I ever saw, right? Who any of them that stepped foot in Vietnam were now service connected or would get service connected. And it was interesting to sort of deal with all this. And the hard part is there's all these other atypical Parkinson syndromes that are way worse, multiple systems atrophy, PSP, corticobasal syndrome, and those guys didn't get crap, right? And because they're not Parkinson's disease. And if you look at the data, there's no study showing that quote-unquote Agent Orange causes Parkinson's disease. There is data that other similar herbicides have a relative risk increase of, or an odds ratio of 2, basically. And so that was apparently enough to service connect all of these veterans. And so it's a really hard thing. The flip side is that I think when I sort of ask about this and all of these MSA patients, PSP patients, and stuff like that, the answer I got from the VA was basically, if there is any concern, the benefit of the doubt always goes to the veteran. And if you think that beyond any reasonable doubt that contributed, or their military service contributed to that disease process, then you've got to give it to them. And I think that's a very low standard, but I think they deserve it. And so I think, and I know Max Herskowitz has looked at this a lot in Houston at the VA there for sleep apnea, sort of the risk of, the exercise regimens, giving bigger neck circumferences, all of this sort of stuff that are related to things that you do to be in military service, and that would be the contributing factor for sleep apnea. But I think the bottom line of what I'm sort of trying to get at is, I came to peace with the fact that basically the benefit of the doubt is always going to go to the veteran, and if there's any reasonable doubt or any reasonable sense that their military service contributed, then we owe it to them. And I know that doesn't sit well always with taxpayers, but I think it's kind of the fair thing to do, and I think that's reasonable. So.
My question was, we have modafinil available that helps promote wakefulness in people that have sleep disorders or shift workers. And why isn't that more readily available, cheaper to the patient, more accepted by the transportation, FAA, even flight attendants who are, jet lagged all the time. They can't get that paid for the insurance company. So, we have these drugs available. Why aren't we promoting that?
It's kind of like the hot potato.
So let me answer that. If you look at the studies closely, one is by Walsh, one by Chuck Seisler. Okay, if you look at the use of modafinil in shift workers and really look at the objective measures using MSLT, there was significant improvement in MSLT, but still abnormal. Okay, so let's say the MSLT at mean was 3, it improved it to about 6. They're significant numerically, but still abnormal. Okay, so using modafinil is no guarantee that the patient will be safer at work. Okay, and no studies have done that. So that's one. But I have to tell you too that the discussions we have today in terms of disability, in terms of aviation safety, these are all politicized. These are all highly politicized. Most of the recommendations are not based on any real evidence. You mentioned a physician from Houston, I won't mention the name, but he was the chief legal counsel for the VA in terms of disability. And he himself went before the board of the VA and said that sleep apnea is not a disability. It is not. Okay. Even if it is a disability, it should not be more than the loss of a limb. And currently it is. Okay? So currently, if you have sleep apnea diagnosed, whether it's mild, you're being reimbursed or you're being paid more each month than you would if you lost a limb. Okay? And I think that is erroneous and that needs to be corrected.
The same thing occurred to me as I was thinking about this topic, but then of course, you've always got unintended consequences no matter what you do. But you put a whole bunch of people on modafinil, who's paying for it, and the potential implications are enormous. But I carry Hippocrates around on here, but among the serious reactions with modafinil, you've got anaphylaxis, Stevens-Johnson's, toxic epidermal necrolysis, arrhythmias, et cetera, psychosis. Yeah, exactly. So all you need is a dozen people with reactions like this, and that'll keep a bunch of law firms busy for the next decade. So, it sounds like it would be a nice way of doing it. I think, coffee with caffeine is probably
That's the stimulus. Well, that would act as an amphetamine, but what worries me more is the other way of this use. Patients come to me, I would say, God, 8 out of 10 are on a hypnotic, and you try to get them off of it, it's like you're So I think wakefulness promoting agent, for me, in my practice, with this person I was talking about, I usually, it's very, individualized, but for that person, I was splitting it in half and having them take half and then half like 4 or 5 hours later. So,
Well, I think.
thoughtful use of any prescription is required.
Exactly, and people who go on hypnotics, and I'm not a big proponent of using hypnotics at all, but they're making individual decisions. If you try to regulate something, then it's a whole different level of complexity.
Yeah, the other thing is, modafinil is even kind of like Viagra. Everybody wants some, and modafinil is used by college students or pre-college students because they do better on their SATs, right? So where do you it's like, but they do better on amphetamines before an SAT too. So I think that you have FDA approval, and if everybody's supposed to do better on their SATs, we'll get it. Back there.
I wonder also about shift work. Having been a nurse, and I remember when I was working nights, and I'd go on vacation and start going to work, and I got back. Like, how many times do people do like sleep diaries, or because I think you can really cut a lot of corners when you work shift work and stuff. And I just wonder if you're addressing sleep hygiene or getting enough information to identify whether it's like a circadian thing or is it just behavioral adaptation to working nights or evenings and just developing bad habits.
I think you're right, and I think every patient should have a sleep diary. In addition, I think that's a good use for actigraphy also to see what's going on, and actually, because subjective and objective are two different things, and every person that says they're not getting enough sleep is getting more sleep than they say they are. So I agree with you. How about the next question back there?
I just wanted to mention, so I do practice at the Gateway Hospital, and I will see probably 3 or 4 patients a week that are either retiring, separating for whatever reason. And there's no mention in the medical records until that very last appointment when I see them. Oh, and by the way, my wife says I scored, so I wanted to evaluate for sleep apnea. And the truth of it is that, and maybe this will help some people that have a hard time with the amount of benefit that the VA is prescribing people today, and that's it. I just spent the first half of the day being convinced that my patients with sleep apnea need better CPAP, need to be on a chronic regimen of how they need to be treated. And in the end, in my role as their primary care doctor, my position is that I need to care for them regardless of where they are, whether they're entering service or exiting service. I care about them as a patient, and in caring about them as a patient, I would feel awful if they left the military with a diagnosis of sleep apnea that had never been made. And so when they leave the military, they have this higher risk of all these things and the increased comorbidity because they didn't have that diagnosis, and they didn't get sleep apnea, they didn't get what they needed. So in the end, I have to look out for them as a person and not just the person who's leaving the military.
Make a comment. I agree completely, okay? But I think one has to make a distinction between the VA providing a lifetime of CPAP service versus the VA providing a lifetime of a disability payment. So if you were diagnosed with sleep apnea, I think we owe it to the military personnel or to the veteran to provide care for the sleep apnea until the day they die. That is our responsibility, and I would argue against anybody who says no. However, to simply pay them, okay, and not care for them, I think is a different matter. And again, that is my viewpoint.
And I think Dr. Dodge and I were just talking about this. I think the hard part is looking at what we know are risk factors for development of sleep apnea. Does military service for that individual contribute to the development of sleep apnea? And I think that's the thing that's almost impossible to answer. But I think in a lot of cases, it's very little. And I think when I leave here, if the sleep business doesn't work out for me, I'm going to start a consulting firm, and I'm going to feed people Taco Bell for 2 weeks prior to their sleep study with Dr. Dodge, and get everybody service connected. Because I think you can induce this, and I think that's a tricky thing. So I say that sort of jokingly, but I do
do
think
it on a 10%
it is very
commission and
hard.
get the $100 a month.
That's right. And all I got to do is I got to get 20 patients, and I'm good.
This was kind of a.
Oh, let's do them in order here. Go ahead.
Here.
Wait for the mic here.
Everybody can hear you.
I have practical question. Help me please understand how military duty predisposed to obstructive sleep apnea.
She wants to know how military duty predisposes to getting obstructive sleep.
In comparison to other professions. So, are we talking about the same nonsense like at prison, person who is in jail suing jail that getting fat have obstructive sleep apnea because did not get proper food, or another person lost weight being in jail again? So I don't understand. It's like,
I think it's hard to
I understand that we need to care about the veterans, we need to care about personnel in military, but be reasonable, right?
No, I think it's hard to understand, mostly because it doesn't make any sense.
Because the rules is right.
Yeah, so I think it was like what Dr. Glass had just mentioned, is that there is no direct line that I can draw between what military service requires of my patients and the diagnosis of obstructive sleep apnea. I'm sure there are some cases out there, but it would be the very, very, very small minority. So I mean, it seems to me like the consensus opinion in here is quite clear, is that the recognition of the diagnosis from the standpoint of treating it effectively is a given. I mean, there's no questioning that. The financial incentive and the way in which the military rates it, that's problematic. And that will change with time, because there are enough people waving hands right now, both wearing a uniform and those who are not. The one other thing that I don't think I had mentioned, I don't want to belabor this point much, is that also keep in mind the potential limitations that this diagnosis, especially with use of CPAP, will place on these individuals from a deployability standpoint, from what their actual job is. And so this would be a good place for me to plug the non-CPAP-based therapies for lots of active duty people, especially these young, healthy guys that would do great either with a surgical evaluation or with use of a dental appliance, or are basically a real kick in the butt to lose weight, lifestyle type stuff. So I think that we should also, and not eat in the hospital cafeteria, so.
There was another question right there?
Yeah, for your chain of custody on the NWT, you require PSP like 4 or drug screen or
Did you get that?
Yeah, the NWT has to be done in the so.
Right. But do you require a PSG to document that they slept the night before, or do you do drug screens?
For MSLT, it is recommended that you do a drug screen. It is required that you do a PSG. With NWT, you don't, okay? Because if you pass, then you pass.
How about if you're on amphetamines? You don't do drug screens?
No, you pass, because your main purpose is to determine that the patient can remain awake. Whether that remaining awake is a function of drugs or function of behavior.
Okay.
If they pass, they pass.
Well, that would go back to what I've asked you before. Do I take them off their drugs before I set them in?
That's don't get the two mixed up. We're talking about MSLT. Yes, they need to be drug-free for 2 weeks beforehand. Any other questions? Yes.
Why are we focusing on the politics in regard to treating a patient? Because the patient has the issue regardless of whether or not they're receiving compensation, and in particular, the incentive to get treatment. But I also see dozens of patients who go their career for going to treatment because they're scared of the
But But like, one thing, remember, it's only for CPAP dependent you get the disability. So say if somebody comes in that has obstructive sleep apnea that you as a clinician feels could be treated by a different modality better, for instance, oral appliance, that patient now has an incentive that no, I don't want to do that. So would you agree? Would you agree with that?
No, I would, yes.
Yeah.
And some of these are, some of this is a gray area too, where it's actually hard to get black and white answers on the CPAP dependent portion of it, which I think is the given for the majority. But the rule holds that for the mild diseases that are treatable with non-CPAP therapy, the treatment can be effective if it's not the limited to the duties or the points of everything that like this one to do.
I have a patient who is retiring from the military, came in, was given a CPAP overseas in Japan, and he was very concerned about showing compliance. He indicated that the military has a very strict standard of compliance and that he and indicated that if he didn't meet that it would jeopardize using that disability.
Yes, so the general requirements for CPAP compliance are the same as it is for CMS. The one population which is different will be some special forces operators and flyers. So pilots, and I can speak only to the Air Force, I don't know what the Army requirements are, but they are very stringent CPAP requirements, and it is 90% compliance at the 4-hour mark over the course of 90 days. Minimum. And so if they don't hit that or exceed it, they do not get what's called an aeromedical waiver to return to flying duty. So in those cases, yes, it is more stringent than the CMS requirements.
Compliant. It's
Is there any
it's much more effective than that, but the compliance rates are 50 to 60%.
Any other questions? Any other closing comments? Okay. Thank you very much. We'll see you tomorrow morning.